Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Beta blockers and calcium channel blockers are medications frequently prescribed for a variety of cardiovascular conditions. These drugs are effective in managing issues such as high blood pressure, arrhythmias, and angina. However, when taken in overdose, they can cause serious, life-threatening complications that primarily affect the cardiovascular system. It is crucial to recognize the potential severity of overdose with these medications promptly. Early detection and aggressive management are essential to reduce the risk of severe outcomes. Supporting the patient through supportive care and administering specific antidotes in a timely manner can significantly improve their chances of recovery. To guide you through this complex toxicology scenario, by the end of this session, you will be able to describe the mechanism of action of beta blockers and calcium channel blockers. You will also be able to explain their effects on the heart and blood vessels. Additionally, you will learn how to recognize the clinical signs of overdose with these medications. Furthermore, the session will cover how the selectivity for beta blockers is lost in overdose situations. You will understand the role of glucagon as an antidote for overdoses of beta blockers and calcium channel blockers, including the recommended dosage and administration procedures. An explanation of the rationale behind using high-dose insulin therapy in such overdoses will be provided, along with an overview of the components and mechanism of action of the glucose-insulin potassium treatment. You will also discuss potential adverse effects and considerations related to this therapy. The session will outline the process for discontinuing the glucose-insulin potassium treatment and emphasize the importance of monitoring after stopping the therapy. Additionally, the rationale for using methylene blue in overdose cases will be explained, alongside the potential roles of phosphodiesterase inhibitors and intravenous lipid emulsion therapy in managing overdoses of lipophilic medications such as beta blockers. The mechanism of action of beta blockers involves their primary function of competitively antagonizing the effects of catecholamines such as epinephrine and norepinephrine. These neurotransmitters play a crucial role in regulating heart rate contractility and vascular tone by binding to beta-adrenergic receptors located in the heart and blood vessels. By blocking these receptors, beta blockers reduce the effects of catecholamines, leading to a decrease in heart rate and blood pressure. This antagonistic action helps in managing various cardiovascular conditions. The endogenous neurotransmitters epinephrine and norepinephrine are essential for the normal regulation of cardiac function and vascular dynamics, and the action of beta blockers on these receptors is central to their therapeutic effects. The cardiac effects of medications such as beta blockers involve several key mechanisms. These drugs decrease heart rate by slowing the spontaneous discharge of pacemaker cells in the sinoatrial node, which is the heart's natural pacemaker located in the right atrium. Both beta blockers and calcium channel blockers can depress activity within this node, leading to a slower heart rate, a condition known as bradycardia. Additionally, these medications inhibit the activity of abnormal pacemakers and slow electrical conduction through the atrioventricular node, which acts as the electrical gateway between the atria and ventricles. This slowing of conduction can result in varying degrees of atrioventricular block. In terms of the force of contraction, beta blockers reduce the contractility of heart muscle by blocking specific adrenergic receptors that normally mediate the stimulating effects of catecholamines on the myocardium. Regarding metabolic effects, beta blockers alter the heart's energy substrate preferences, shifting from the use of free fatty acids to carbohydrates. They may also induce an energy deficit in the heart by lowering the myocardial metabolic rate. The vascular effects of beta blockers, particularly those that block beta-2 adrenergic receptors, include promoting vasoconstriction by inhibiting the vasodilatory effects of catecholamines on blood vessels. However, the clinical significance of this vasoconstriction can be difficult to determine because of the complex interaction between the effects on the heart and the peripheral blood vessels. Selectivity is often lost when beta blockers are taken in overdose. These medications are typically classified based on their preference for the beta-1 adrenergic receptor. However, at higher doses, this selectivity diminishes, and drugs designed to target only the beta-1 receptor may also inhibit the beta-2 receptor. Beta-1 receptors are primarily located in the heart, which is why beta-1 selective beta blockers are frequently chosen to treat cardiovascular conditions while minimizing effects on other organs such as the lungs. Nonetheless, this selectivity is compromised in overdose situations. For example, metoprolol is classified as a beta-1 selective beta blocker. At therapeutic doses, it primarily binds to beta-1 receptors, which are mainly found in the heart. This selective action helps reduce potential side effects on other tissues. However, when taken at higher doses, metoprolol begins to block beta-2 receptors as well. These receptors are present in various tissues, including the lungs, blood vessels, and liver. Blocking beta-2 receptors can lead to a wider range of side effects. In the lungs, beta-2 receptors are responsible for bronchodilation, which helps open the airways. When these receptors are blocked, it can cause bronchoconstriction, a narrowing of the airways, which may result in difficulty breathing, especially in individuals with asthma or chronic obstructive pulmonary disease. In blood vessels, beta-2 receptors promote vasodilation, the process of widening blood vessels. Blocking these receptors can cause vasoconstriction, which may worsen low blood pressure in overdose situations. Additionally, beta-2 receptors are involved in various metabolic processes, including the regulation of glucose. Their blockade can interfere with normal glucose metabolism, potentially leading to hypoglycemia, a condition characterized by low blood sugar levels. This is particularly concerning in cases of beta blocker overdose. Intrinsic sympathomimetic activity refers to the ability of certain drugs to stimulate beta-adrenergic receptors to some degree while primarily acting as antagonists. Examples of such drugs include acebutolol, alpranolol, carteolol, oxprenolol, penbutolol, pindolol, and celiprolol. These beta blockers with intrinsic sympathomimetic activity can partially mimic the effects of natural catecholamines in the body, such as epinephrine and norepinephrine. While the presence of intrinsic sympathomimetic activity may theoretically limit the severity of a beta blocker overdose, it can also induce sympathomimetic effects. These effects include increased heart rate and elevated blood pressure, which can complicate the clinical management of such overdoses. Membrane stabilizing activity is exhibited by some beta blockers, also known as sodium channel blockade. Drugs such as acebutolol, alpranolol, betaxolol, carvedilol, oxprenolol, and propranolol can cause intraventricular conduction delay. The membrane stabilizing effects of these medications typically only contribute to toxicity in overdose situations. Blocking sodium channels can further slow the heart rate and impair the conduction of electrical impulses through the heart, potentially leading to bradycardia, atrioventricular block, and even complete cessation of heartbeat, known as asystole. The membrane stabilizing activity can also contribute to hypotension by reducing cardiac output, particularly in cases where the beta blocker has vasodilatory properties. In some instances, this activity may predispose individuals to ventricular arrhythmias, especially when combined with other factors such as electrolyte imbalances. Lipid solubility of certain drugs influences their ability to cross biological barriers and their potential side effects. Bopindolol, carvedilol, penbutylol, pindolol, and propranolol are among the drugs whose properties are affected by lipophilicity. The measure used to evaluate this characteristic is called the logarithm of the distribution coefficient, or log D. A higher log D value indicates that a drug is more lipophilic, meaning it has a greater affinity for fats and lipids. For example, propranolol has a log D value of approximately 0.99, indicating a relatively high degree of lipophilicity. In contrast, atenolol has a log D of about -2.03, suggesting it is much less lipophilic. Lipophilic drugs like propranolol are capable of readily crossing the blood-brain barrier. This ability makes them more likely to cause central nervous system toxicity, especially in overdose situations. In cases of overdose, lipophilic agents are associated with severe neurological effects such as delirium, coma, and seizures. These effects can occur even in the absence of hypotension, highlighting the importance of understanding a drug's lipophilicity when considering its safety profile. Potassium channel blockade by certain beta blockers, such as sotalol, can lead to prolongation of the QT interval on the electrocardiogram, which increases the risk of ventricular dysrhythmias. Some beta blockers, including carvedilol and labetalol, possess vasodilatory properties, and the interaction between these effects and their beta-blocking activity can become quite complex in cases of overdose. Additionally, overdoses involving beta blockers combined with calcium channel blockers present particular challenges, as the synergistic toxicity of these medications complicates management. Propranolol is a lipophilic beta blocker with membrane-stabilizing activity, and it is frequently associated with severe or fatal ingestions. Overdose of propranolol can lead to serious complications such as coma, seizures, low blood pressure, slow heart rate, impaired atrioventricular conduction, and a widened QRS interval on the electrocardiogram. Additionally, ventricular tachyarrhythmias and a Brugada pattern on the electrocardiogram may also occur. Atenolol is the least lipid-soluble beta blocker and is considered one of the safer options in overdose situations. However, it is still possible to experience severe toxicity and cardiovascular death following an overdose of atenolol. Sotalol is a beta blocker that also blocks potassium channels. Its overdose can prolong the QT interval on the electrocardiogram and cause ventricular dysrhythmias, including torsades de pointes. Other agents, such as acebutolol, betaxolol, and oxprenolol, have significant membrane-stabilizing activity and have been associated with fatalities in overdose cases. The presentation of patients who overdose on beta blockers generally includes low blood pressure and slow heart rhythms. The exact clinical picture varies depending on several factors, such as the amount of the drug ingested, the patient's underlying health status, and the specific type of beta blocker involved. Treatment for beta blocker overdose primarily involves aggressive supportive care. Further details on management will be discussed shortly. The mechanism of action of calcium channel blockers involves inhibiting the influx of calcium ions through L-type calcium channels. These channels are primarily located in cardiac muscle and vascular smooth muscle cells. By blocking these channels, calcium availability for excitation contraction coupling decreases, which leads to reduced myocardial contractility and vasodilation. L-type calcium channels play a crucial role in the process of excitation contraction coupling in both cardiac and smooth muscle cells. Unlike beta blockers, which do not directly interact with these channels, calcium channel blockers specifically target them to produce their therapeutic effects, as well as potential toxic effects. In terms of cardiac effects, calcium channel blockers, especially non-dihydropyridine types such as verapamil and diltiazem, decrease heart rate by inhibiting the inward calcium current responsible for spontaneous depolarization in pacemaker cells of the sinoatrial node. These drugs also reduce myocardial contractility by interfering with calcium-dependent excitation contraction coupling within cardiac myocytes. Verapamil and diltiazem tend to have more significant effects on the heart compared to dihydropyridines. Furthermore, calcium channel blockers slow conduction through the atrioventricular node, which can lead to varying degrees of atrioventricular block. Among these, verapamil exhibits the most potent effect on atrioventricular nodal conduction. Vascular effects of calcium channel blockers involve relaxation of vascular smooth muscle, which results in vasodilation and a subsequent reduction in blood pressure. Among these medications, dihydropyridines tend to have a higher affinity for calcium channels located in blood vessels, making them more potent vasodilators compared to other types such as verapamil and diltiazem. This difference in affinity contributes to their distinct effects on the cardiovascular system. Calcium channel blockers, specifically non-dihydropyridines such as verapamil and diltiazem, inhibit the sinoatrial and atrioventricular nodal tissues. This inhibition leads to a decrease in heart rate and conduction velocity within the heart. These medications bind non-selectively to L-type calcium channels found in both vascular and cardiac tissues. When overdosed, non-dihydropyridines primarily impact cardiac function. This results in conditions such as bradycardia, atrioventricular block, and hypotension. The predominant effect on the heart is due to these agents' greater affinity for the myocardium compared to dihydropyridines. As a consequence, hypotension primarily occurs because of decreased cardiac output stemming from the negative effects on heart rate and contractility. A prospective study conducted by a poison control center observed that atrioventricular nodal block was more frequently associated with verapamil poisoning. Dihydropyridines such as amlodipine, felodipine, isradipine, nicardipine, nifedipine, nimodipine, nisoldipine, and nitretipine primarily act on vascular smooth muscle, causing vasodilation. This selectivity is due to their preferential binding to L-type calcium channels located in vascular tissue. Overdose of these medications predominantly affects peripheral vascular tone, which can lead to hypotension and reflex tachycardia. The baroreceptor reflex responds to the decrease in blood pressure by triggering an increase in heart rate. However, in severe cases, the drug's selectivity for vascular tissue can be lost, resulting in bradycardia. Hypotension may be caused by decreased peripheral vascular resistance or cardiac pump failure. In a study of hospitalized patients with calcium channel antagonist overdose, it was found that 43% of the patients experienced hypotension, defined as a systolic blood pressure less than 100 millimeters of mercury. Additionally, 8% of patients had a systolic blood pressure less than 60 millimeters of mercury. Hyperglycemia is a common feature observed in cases of overdose involving both dihydropyridine and non-dihydropyridine medications. However, it tends to be more pronounced with non-dihydropyridines. This difference is due to their more potent inhibition of insulin release from pancreatic beta cells, a process that relies on L-type calcium channels. In fact, a retrospective study analyzing overdoses of verapamil and diltiazem found that an increase in the peak glucose concentration was a better predictor of illness severity than hemodynamic disturbances. The study also identified that a verapamil concentration of 5 micromoles was highly sensitive and specific in indicating a 2.76-fold increase in the odds of fatality. Treatment of overdose cases involving beta blockers and calcium channel blockers primarily centers on providing aggressive supportive care. This approach includes managing the airway, ensuring proper breathing, and maintaining circulation, often referred to as the ABCs. Fluid resuscitation is also a key component to stabilize the patient. Additionally, vasopressor medications may be administered if necessary, although their effectiveness can be limited in the absence of specific antidotes. Glucagon is a polypeptide hormone produced by alpha cells in the pancreas. It plays a crucial role in regulating blood sugar levels by counteracting the effects of insulin, primarily by raising blood glucose levels. Beyond its metabolic functions, glucagon also has significant effects on the cardiovascular system. One of the main roles of glucagon is in reversing hypoglycemia, a condition characterized by dangerously low blood sugar levels. During hypoglycemia, glucagon stimulates the liver to break down stored glycogen into glucose, a process known as glycogenolysis. The released glucose then enters the bloodstream, helping to restore normal blood sugar levels. However, glucagon may not always be effective in correcting hypoglycemia, especially in cases where glycogen stores are depleted. This situation can occur during prolonged fasting or in individuals with severe liver disease. In such cases, administering intravenous dextrose is preferred because it does not rely on glycogen stores for its effect. In addition to its role in glucose regulation, glucagon has notable effects on the heart. It has positive inotropic effects, which increase the force of heart contractions, and positive chronotropic effects, which raise the heart rate. Glucagon exerts these effects by binding to specific receptors in the heart. These receptors are connected to GS proteins, which, upon activation, stimulate an enzyme called adenylate cyclase. This enzyme converts ADP, the energy currency of the cell, into cyclic adenosine monophosphate, a messenger molecule that influences various cellular processes. The rise in cyclic adenosine monophosphate levels leads to an increase in intracellular calcium concentration. Glucagon enhances calcium influx through calcium channels and promotes calcium release from the sarcoplasmic reticulum, a specialized internal store for calcium in muscle cells. This release is facilitated by the activation of protein kinase A, an enzyme that phosphorylates proteins involved in calcium handling, thereby increasing calcium availability. Additionally, glucagon inhibits an enzyme called phosphodiesterase, which normally breaks down cyclic adenosine monophosphate. By inhibiting this enzyme, glucagon prolongs the effects of cyclic adenosine monophosphate, further enhancing its positive effects on heart contractility and rate. Glucagon also influences the homeostasis of other ions such as potassium and sodium. For instance, it can cause hypokalemia, a condition characterized by low potassium levels in the blood. These effects on ion balance are part of glucagon's broader impact on the cardiovascular system. In cases of adult patients experiencing toxicity from beta-blocker overdose, an initial dose of 3 to 5 milligrams of glucagon should be administered intravenously over a period of 1 to 2 minutes. For pediatric patients, the starting dose is calculated based on body weight at 50 micrograms per kilogram. If the initial dose does not elicit an adequate response, additional doses should be given in a titrated manner up to a total of approximately 10 milligrams. Once a response is observed, a continuous infusion of glucagon should be initiated. The infusion rate is determined by the dose that produced the initial response. For example, if a patient responded after receiving 7 milligrams of glucagon, the infusion should commence at a rate of 7 milligrams per hour. Even if administering the full 10 milligram dose does not fully restore blood pressure and heart rate, it is still advisable to start the glucagon infusion at 10 milligrams per hour. This approach may be beneficial because glucagon can work synergistically with other antidotes that might be administered later. It is important to emphasize that glucagon must be administered slowly to reduce the risk of adverse effects such as nausea and vomiting. Due to its short half-life, repeated doses or continuous infusions may be necessary to maintain the desired therapeutic effects. Throughout treatment, careful monitoring of the patient's hemodynamic responses, blood glucose levels, and potential adverse effects is essential. Finally, glucagon should be viewed as a temporary measure while preparing for more definitive therapeutic options, such as high-dose insulin therapy, especially in severe cases of beta-blocker toxicity. Insulin release from the beta cells of the pancreas is mediated through calcium influx via L-type calcium channels and requires the presence of ADP. Calcium channel blockers inhibit the release of insulin by blocking calcium entry through these channels. This interference results in insufficient insulin to meet the glucose demands of the stressed heart and contributes to hyperglycemia, which can occur during toxicity from calcium channel blockers. When insulin binds to its receptor, it stimulates the entry of glucose into cells through a series of phosphorylation reactions that involve enzymes such as phosphatidylinositol 3 kinase and protein kinase B. These reactions lead to the recruitment of glucose transporters from within the cell to the cell membrane, facilitating glucose entry. Calcium channel blockers interfere with this pathway by inhibiting protein kinase B, thus hindering the recruitment of glucose transporters. This disruption creates a state of insulin resistance, which may explain the necessity for high doses of insulin to treat myocardial depression caused by these drugs. The glucose-insulin potassium treatment involves the intravenous administration of several components. Glucose, often in the form of concentrated dextrose solutions such as D50, is used to provide a source of sugar. Regular human insulin is administered in high doses to facilitate the treatment. Potassium supplementation is also given to manage low potassium levels, which is a common side effect of insulin therapy. This treatment is not a fixed regimen. Instead, the doses of each component are adjusted based on the patient's individual needs and their response to the therapy. The primary goal of this approach is to maintain normal blood glucose levels, a state known as euglycemia, while administering high doses of insulin. This strategy aims to improve cardiac function and overall tissue perfusion. The exact mechanisms by which glucose-insulin potassium treatment functions are not yet fully understood, but several key factors have been identified. During periods of stress, heart muscle cells tend to switch from using free fatty acids to carbohydrates as their primary source of energy. Certain substances, such as calcium channel antagonists, can inhibit this shift, which leads to decreased heart contractility. Conversely, administering insulin externally increases glucose uptake by the heart muscle cells, resulting in improved contractility. Insulin also acts as a vasodilator for the blood vessels throughout the body, including those supplying the heart and lungs. This effect is partly due to its capacity to enhance the activity of enzymes responsible for producing nitric oxide in the endothelium, which reduces resistance in the blood vessels. As a result, the heart works more efficiently and cardiac output increases without imposing additional workload or oxygen demand, unlike vasopressor medications. Furthermore, insulin influences calcium signaling within heart cells. It promotes the influx of calcium across cell membranes by accelerating the reverse operation of the sodium-calcium exchanger. High doses of insulin also help regulate calcium levels in the cell cytoplasm by boosting the activity of enzymes involved in calcium storage within the sarcoplasmic and endoplasmic reticulum. This regulation enhances the heart muscle's ability to contract more effectively by increasing the binding of specific proteins involved in muscle contraction, thereby improving the process of excitation-contraction coupling. The initial bolus involves administering 1 unit per kilogram of regular human insulin intravenously. Simultaneously, a dextrose bolus of 0.5 grams per kilogram is typically given along with the insulin, unless the patient's blood glucose level is already elevated beyond 300 milligrams per deciliter or 16.7 millimoles per liter. For continuous infusion, the starting rate is usually between 1 and 2 units per kilogram per hour. The infusion rate can be increased by 1 to 2 units per kilogram per hour every 10 to 15 minutes, depending on the patient's hemodynamic response. There is no firmly established maximum dose. Doses up to 10 units per kilogram per hour are commonly reported, with some cases documenting successful treatment with even higher doses, including one instance where a patient received 23 units per kilogram per hour. The typical duration of insulin infusion ranges from 24 to 48 hours, but it can be as brief as 45 minutes or extend up to 96 hours, depending on the patient's response and the duration of drug toxicity. Frequent blood glucose monitoring is vital. Initially, measurements should be taken every 10 minutes, followed by every 30 to 60 minutes once blood glucose stabilizes. The dextrose infusion rate must be adjusted to maintain blood glucose within a target range of 100 to 200 milligrams per deciliter. Due to the high concentration of dextrose solutions, It is strongly recommended to administer the infusion through a central line in order to avoid vein irritation and potential complications. The primary goal is to maintain the patient's hemodynamic stability after discontinuing insulin and dextrose. This involves ensuring adequate perfusion of vital organs, which can be assessed through various factors such as mental status, skin temperature and color, peripheral pulse presence, urine output, and vital signs. However, it is important to note that traditional parameters like blood pressure and heart rate might not fully reflect organ perfusion. If the patient becomes hemodynamically unstable during or after the process of weaning from insulin and dextrose, it may be necessary to restart or adjust the infusion. Additionally, other supportive therapies such as vasopressor medications might need to be considered. While glucose-insulin potassium treatment can be highly effective, healthcare providers must be aware of potential adverse effects and special considerations. One significant risk is hypoglycemia, which can develop rapidly and lead to severe complications. Therefore, frequent monitoring of blood glucose levels and prompt adjustment of dextrose infusion are essential to mitigate this risk. Insulin can also cause potassium to shift into cells, potentially leading to hypokalemia. Close monitoring of potassium levels and supplementation when necessary can help prevent serious complications. Moreover, insulin therapy can influence other electrolytes such as magnesium and phosphorus, requiring regular monitoring and supplementation if needed. Finally, there is a risk of fluid overload, especially in patients with underlying heart or kidney conditions, as concentrated dextrose solutions can contribute to excess fluid accumulation. Careful management of fluid intake is crucial in these cases. Discontinuing glucose-insulin potassium treatment requires a gradual and closely monitored approach. Because there are no standardized guidelines, the process must be tailored to the individual, considering the patient's response and clinical condition. Typically, insulin infusion is tapered gradually rather than abruptly stopped to prevent rebound hypoglycemia, and continued infusion of dextrose might be necessary even after stopping insulin to maintain normal blood sugar levels and support recovery. Extended monitoring remains essential because the risk of hypoglycemia and electrolyte imbalances persists significantly after insulin discontinuation. High doses of insulin therapy tend to have a longer duration of action and half-life than standard insulin management for diabetes, which can prolong the risk of hypoglycemia for up to 24 hours after infusion stops. Therefore, it is crucial to monitor blood glucose levels regularly even after stopping insulin. The extended effects may be due to the prolonged toxicokinetics of the overdosed drug, indicating that the body might still be affected even after insulin cessation. When discontinuing this treatment, it is important to consider certain factors. For example, using a concentrated insulin solution, such as 10 units per milliliter, is strongly recommended to prevent fluid overload, especially at higher infusion rates. Collaborating with hospital pharmacy services is usually necessary for this adjustment. Regular monitoring of serum potassium levels is also vital, because insulin therapy can commonly cause hypokalemia, a condition characterized by low potassium levels in the blood. Moreover, pre-existing health conditions like diabetes, kidney failure, or electrolyte abnormalities can significantly influence dosing and monitoring requirements, highlighting the importance of individualized care during the cessation process. Generally, when treating toxicity from beta blockers and calcium channel blockers, it is recommended to administer glucagon first. If the patient does not respond adequately to glucagon, high-dose insulin therapy should then be considered. Using glucagon as a first-line agent is advised because it has a relatively benign side effect profile, making it suitable for early use in serious cases. This recommendation is based on glucagon's ability to rapidly increase heart rate and improve the strength of heart contractions. It achieves this by mechanisms that bypass blocked beta-adrenergic receptors or inhibited calcium channels, which are the targets of the toxic agents. However, the effects of glucagon tend to be transient. Therefore, it is best employed as a temporary measure while preparing for more definitive therapies such as high-dose insulin treatment. In cases where patients do not respond sufficiently to glucagon, high-dose insulin therapy is recommended, especially in severe poisonings involving significant impairment of myocardial function. High-dose insulin can improve cardiac function through various mechanisms. It enhances calcium processing within the heart muscle, increases glucose uptake and utilization as an energy source, and may also help improve vascular tone. This approach ensures that the patient receives a quick initial response with glucagon, followed by more sustained support with insulin if necessary. In the management of critically ill patients, a stepwise approach is generally recommended to allow for the assessment of each intervention's effectiveness. However, these patients might require the simultaneous administration of multiple therapies. For instance, high-dose insulin therapy may be initiated early in the resuscitation process alongside other supportive measures such as vasopressors. This is particularly relevant given the delayed onset of insulin's action, which typically occurs between 15 to 40 minutes when used at standard therapeutic doses for conditions like hyperglycemia or diabetes. It is important to note, however, that the onset of action for insulin in this specific indication may be less than 5 minutes, differing from its usual onset when used for its standard purpose. When managing blood glucose, potassium levels, and other markers of organ perfusion during treatment, close monitoring is essential. Pre-existing medical conditions such as diabetes or kidney failure can greatly influence the appropriate dosing and the frequency of monitoring required for both insulin and glucagon. In such cases, it is necessary to adjust dosing regimens and increase the monitoring frequency to ensure safety and efficacy. The evidence supporting high-dose insulin therapy has notable limitations. Much of this evidence is derived from animal studies and case reports, with limited data from randomized controlled trials comparing high-dose insulin to other treatment options. However, emerging research suggests that high-dose insulin therapy may be effective and safe in managing cardiovascular shock resulting from various poisonings. Phosphodiesterase inhibitors are not commonly considered a treatment option, and there are valid reasons for their limited use. Although their pharmacology suggests that they could fit into certain treatment pathways, they are not without risks and may complicate the clinical picture. It is important to be aware of these medications as potential third or fourth-line options. However, their placement in treatment plans reflects how we should evaluate these drugs, the mechanisms by which they may act in this context, and the evidence supporting their use. Regarding their mechanism of action, phosphodiesterase inhibitors such as inamrinone and milrinone work by inhibiting the enzyme phosphodiesterase, which normally breaks down cyclic adenosine monophosphate. This increase in cyclic adenosine monophosphate levels can influence cardiac function. In addition, beta blockers reduce cyclic adenosine monophosphate levels in the heart, leading to decreased cardiac contractility. By inhibiting phosphodiesterase, these agents theoretically increase cyclic adenosine monophosphate levels independently of beta-adrenergic receptor stimulation, potentially counteracting the negative inotropic effects caused by beta blockers. Theoretical benefits. Phosphodiesterase inhibitors could have a positive chronotropic effect, which means they may increase heart rate in the myocardium because they raise intracellular cyclic adenosine monophosphate levels. Animal studies have demonstrated that these agents can increase cardiac index, limited evidence and conflicting data. Despite the potential benefits, there is a lack of robust clinical data to support the routine use of phosphodiesterase inhibitors in cases of beta blocker poisoning. Most of the evidence available comes from uncontrolled clinical cases and case reports, which do not provide conclusive proof of their efficacy. Additionally, some studies using canine models of propranolol toxicity have shown that the combination of glucagon with a phosphodiesterase inhibitor was less effective than glucagon alone. Potential role in bronchospasm. Phosphodiesterase inhibitors, particularly aminophylline, may be considered as an alternative approach to bronchodilation for treating bronchospasm caused by beta blocker poisoning. In these cases, the bronchospasm results from blockade of beta-2 receptors in the lungs rather than inflammation. This distinction makes traditional beta-agonist bronchodilators less effective. Similar to milrinone, methylene blue is considered a last-line treatment option. Its mechanism of action is intriguing, and it is increasingly being supported for use in various conditions such as septic shock, making it worth considering in this context. Methylene blue interacts with enzymes within red blood cells to lower methemoglobin levels. Under normal circumstances, an enzyme called NADH-dependent cytochrome B5 reductase maintains methemoglobin concentrations below 1% of the total hemoglobin. However, during oxidative stress, this enzyme's capacity can be overwhelmed, causing methemoglobin levels to rise, a condition known as methemoglobinemia. Methylene blue activates an alternative enzyme called NADPH-dependent methemoglobin reductase. This enzyme reduces methylene blue to leukomethylene blue, which in turn reduces the ferric iron in methemoglobin, converting it back to functional hemoglobin. In cases of overdose with beta blockers or calcium channel blockers, methylene blue works by blocking an enzyme called guanylate cyclase. This reduces the excessive production of nitric oxide, a molecule that causes relaxation of vascular smooth muscle. By doing so, methylene blue helps restore vascular tone and increases blood pressure. Additionally, methylene blue specifically inhibits inducible nitric oxide synthase, an enzyme involved in the production of nitric oxide, as well as soluble guanylate cyclase, an enzyme downstream in this pathway. Its effects on vascular pressure have been shown to help restore proper regulation of blood vessels when nitric oxide production is abnormally increased. Methylene blue can be administered intravenously with a typical dose ranging from 1 to 2 milligrams per kilogram of body weight. Continuous intravenous administration of this medication is not recommended because it may lead to hemolytic anemia, a condition where red blood cells are destroyed prematurely. The effectiveness of methylene blue may be limited in certain patients. It may not work well in individuals with specific medical conditions such as glucose 6-phosphate dehydrogenase deficiency, sulfamoglobinemia, and some other enzyme deficiencies. These conditions can interfere with the drug's mechanism of action or increase the risk of adverse effects. Lipid emulsion therapy is a complex treatment decision. While it can be used in various clinical scenarios, I will not go into detailed specifics here. Instead, I will address this topic more thoroughly in a future lecture focused on treatment for bupropion overdose. Lipid rescue therapy is considered when managing overdoses of lipophilic or fat-soluble medications. Although the exact mechanisms behind this therapy are not fully understood, several proposed mechanisms have been suggested. One such mechanism is the lipid sink effect, in which the lipid acts as a reservoir for lipophilic drugs. This effect draws the drugs away from their target tissues and into the bloodstream, where they can be metabolized and eliminated. Additionally, lipid may enhance myocardial metabolism by providing energy substrates, which can improve cardiac function. This process potentially bypasses any cardiac energy demand that has been blocked by certain drugs such as beta blockers, calcium channel blockers, or local anesthetics. Finally, lipid therapy may help stabilize cell membranes, preventing further damage caused by toxic substances. Future lectures, particularly the session on bupropion, will explore this subject in more detail. Overdoses involving beta blockers and calcium channel blockers require aggressive management to prevent cardiovascular collapse. Key therapies include the use of glucagon and high-dose insulin. Understanding how these medications work and being aware of their potential side effects are essential for successful patient management. Further research is necessary to establish the most effective treatment protocols and to evaluate the role of other therapeutic options. Beta blocker and calcium channel blocker overdoses necessitate aggressive management to prevent cardiovascular collapse. Glucagon and high-dose insulin are considered key therapies. Glucagon is often used as a temporary measure, while high-dose insulin serves as a more definitive treatment for severe cases. It is crucial to understand their mechanisms of action, proper dosing, and potential side effects to ensure successful patient management. Other treatments, such as phosphodiesterase inhibitors, methylene blue, and intravenous lipid emulsions may play roles in specific scenarios, often as last resort options. Continued research is needed to optimize treatment protocols and better evaluate the roles of these and other therapeutic strategies.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.